All right. Good afternoon, everyone, and welcome to the Michigan Critical Access Hospital Benchmarking Solution. For those who do not know me, my name is Jeff Naj from the Michigan Center for Rural Health. There will be a number of different presenters throughout the presentation who have collaborated on this initiative. So the CA Analytics solution is designed to help Michigan Critical Access hospitals enhance productivity and clinic workflow through insightful real-time data. The solution was developed by Eid Bailey in collaboration with the Michigan Center for Rural Health. The solution allows hospital leaders to access benchmarking data, visualize key indicators, and make informed decisions with ease. Developing the CAH benchmarking solution. So, what was the why? Well, as part of our ongoing efforts, MCRH leverages Flex grant funds to provide financial and operational support to Michigan critical access hospitals. This involves offering robust resources and technical assistance to help deliver quality care. One key approach we've implemented is benchmarking, which allows hospitals to compare their performance against peers, identifying ways to boost productivity and improve overall operation. What was the process we went through? Well, believe it or not, we began this process or this initiative with a financial and operational survey almost a year ago today. We then followed up by reaching out to a small group of CFOs, of Michigan CFOs, I should say, to better understand their needs. And based on the feedback they provided and previous benchmarking efforts, we partnered with Eid Bailey to develop a custom solution. The solution was then piloted by 3 Michigan critical access hospitals, allowing us to refine and ensure that the tool meets specific operational and financial needs of these hospitals. So who were the partners? We had Terry Lutz, CFO, Sure Health, Andrew Raymond, CFO, Kalkaska Memorial Health Center, Emily Emery Shea, CFO, Helen Newberry Joy Hospital, and then, of course, our friends from Eid Bailey, Houston Clayson, Business Development, Sam Olson, Manager, and Paul Schultz, Senior Manager. Jill Osterly from the center also was heavily involved in this project, along with myself and a number of other individuals at the center. So our goals for the CH benchmarking solution, our primary goals, of course, with the solution are to empower our Michigan CAs by making their data transparent and easily accessible, even across different systems. This transparency allows hospitals to gain insights into how they are allocating their resources, which leads to more informed decisions. By driving process improvements, we empower hospitals to streamline their workflows, optimize resource allocation, and boost productivity. One key outcome is to maximize return on investment, as hospitals can reduce their dependency on possibly contract employees, cut overtime, and more. With the right data at their fingertips, hospitals can identify bottlenecks in patient flow and address barriers. This results in a more streamlined operations and better patient experience. Additionally, with the operational improvements, this is going to lead to increased staff satisfaction as well as employees will see more efficient processes in place. Importantly, we've designed the solution to be both cost-effective and highly impactful, ensuring that even small rural hospitals will have great benefit.
All right. Thank you, Jeff, for kicking things off. I just want to speak a little bit to the process of how we built this and kind of get from point A to point C, really. The process for building this solution is really straightforward. We wanted to make it that way for you users. First, we work with your hospital to identify the specific reports from your systems and the formats needed to meet our requirements. Then once that's been established, the hospitals will export those reports from their systems and upload them to a dedicated SharePoint site that has been set up for you by Eid Bailey. Once this is set up and the first upload is made to that dedicated SharePoint site, all of the data processing and logic and really all the back-end work behind the scenes is done. So from there, hospitals only need to upload their reports once a month, and the system takes care of the rest, minimizing ongoing effort for you as the hospitals and providing you with the latest insights automatically. So once reports are uploaded to that SharePoint site, there's really no turnaround time. The system updates automatically, and you're left with the latest insights, ensuring you can analyze and make the appropriate comparisons. So now that we've walked through that process of building the solution, I'd like to show you a quick demo to highlight the solution in action. So this demo will walk you through the user interface, really just showcasing how easy it is to access and navigate the benchmarking data. You'll see firsthand how hospitals can quickly generate insights and then compare your performance to your peers across Michigan, which is really what we're here for.
Hi, and welcome. Today, I'll be showcasing a benchmarking solution developed specifically for critical access hospitals through a partnership between Eide-Bailly and the Michigan Center for Rural Health. This solution leverages business intelligence through Microsoft Power BI to provide detailed and comparative insights into hospital department volumes, labor, and productivity, as well as clinic volumes and efficiency. Additionally, it draws on Eide-Bailly's expertise and data insights in the critical access hospital space, ensuring that hospitals can confidently compare themselves to peers and make data-driven decisions for improvement. Before we look at any of the dashboards, I want to quickly highlight some key features of the solution. The heart of the platform is the group benchmarking, where hospitals can compare department labor, volume, and productivity data across peers. We also provide clinic comparison, where we break down volume in the clinic by completed versus missed appointments, as well as the visit time. Lastly, we've built a series of tailored individual hospital dashboards that provide deeper insights unique to each hospital. As I walk through the dashboards, you'll notice that you can adjust parameters such as peers, bed size, and gross revenue, ensuring accurate comparisons are made. Let's explore the labor and volume comparison dashboards together, as they offer a comprehensive view of how your hospital's staffing and service demand align with your peers. The labor comparison dashboard allows you to see how your department's labor distribution compares to others, helping you identify any differences in staffing patterns and workforce allocation. Simultaneously, the volume comparison dashboard provides insights into departmental service demand, showing the types of services delivered and how these volumes fluctuate across departments. By analyzing both labor and volume, you can gain a deeper understanding of how effectively resources are being utilized to meet patient needs. I'll now demonstrate how easily you can adjust parameters and explore these dashboards for valuable insight. Let's take a look at the department service mix and department labor mix dashboards. Together, these dashboards provide a comprehensive view of how hospitals allocate both their labor and resources to deliver patient care. The department service mix dashboard offers insights into revenue codes and the type of services provided, helping hospitals identify opportunities for more accurate billing and resource utilization. Meanwhile, the department labor mix dashboard breaks down how staffing is distributed across departments, allowing hospitals to compare their staffing models with peers. By analyzing both service delivery and labor allocation, hospitals can uncover areas for operational improvement, such as adjusting staffing models or refining coding processes. I'll now demonstrate how both dashboards can be filtered by time period and department to reveal deeper insights into these aspects. Let's shift our focus to the MCRH individual hospital segment of the solution. First, we'll look at the hospital department productivity dashboard. This dashboard provides a comprehensive view of the selected departments for your hospital, showing productive hours compared to volume, and ultimately the department's productivity compared to the Eide-Bailly benchmark and the Michigan average. I'll switch between several departments to see how easy it is to navigate. I'll also demonstrate how you can quickly access additional insights by hovering over a specific period, allowing us to view the service mix for that period and understand how it may have impacted productivity. Next, let's look at the department labor and volume forecast dashboards. These dashboards not only analyze historical performance data, but also provide forecasts, allowing your hospital to align labor resources with projected patient volumes. This dual approach helps you understand past trends while planning ahead for better operational efficiency and resource management. Let's now turn back to the MCRH benchmarking group segment of the solution, where we'll look at the productivity quadrant dashboard. This dashboard offers a powerful comparative view of your department's performance by mapping labor hours against volumes relative to your peers. It highlights areas where your department may be more or less efficient, enabling you to quickly pinpoint whether you're operating with high or low productivity. There are several more dashboards available in this solution, each offering valuable insights and analysis into your hospital's performance. For the sake of time, I'll briefly touch on a few of them, but feel free to explore these further in more detail during a tailored demo or our upcoming webinar. First, we have the summary comparison dashboard, which provides an overview of your hospital's productivity, labor, and volume for a selected department compared to your peers. Then, the variance heat map dashboard visually highlights which departments in your hospital are furthest from the benchmark and may need more guidance. We'll also look at the clinic volume dashboard, where hospitals are provided with insights into clinic flow and the types of care being provided, broken down by visit type. This allows hospitals to identify where clinic volume is strong and where there may be opportunities based on volume that's not being captured. Finally, to make things really clear for users and ensure we're comparing hospitals appropriately, there are built-in data dictionaries that clarify data sources, methodologies, and calculations, ensuring transparency and understanding by all. Now, let's recap the benefits. By providing trusted data, clear benchmarks, and guidelines, this solution helps your hospital, number one, identify areas for operational improvement. With productivity and labor data at your fingertips, you'll be able to see where adjustments can be made to improve department efficiency. Number two, enhance decision making. The dashboards provide actionable insights that support data-driven decisions, ultimately leading to better resource allocation and cost savings. Number three, compare meaningfully to your peers. By comparing yourself to similar hospitals, you'll gain an understanding of how your organization is performing in key areas, helping you set realistic targets and drive improvement. This solution doesn't just provide data, it provides context that can lead to meaningful improvements in your hospital's operations. In conclusion, our CAH benchmarking solution offers comprehensive insights through intuitive dashboards and peer comparisons. To learn more, please contact the Michigan Center for Rural Health to register for our upcoming webinar on October 8th, where you'll hear from the CFOs of 3 Michigan critical access hospitals currently using this solution. Additionally, we'll be attending the 2024 Michigan Critical Access Hospital Conference on November 7th and 8th in Traverse City, and we would love to connect with you there in person. Thank you for your time today. I hope this demo gave you a helpful overview of how our CAH benchmarking solution can improve your hospital's operational efficiency and resource management. We'd love to continue the conversation, so please feel free to reach out if you have any questions. Thanks again and have a great day.
I'll just add one more note there. Thank you all for your time and watching that. If there's any questions regarding anything you saw with the solution, I want to make sure we stay on schedule here. So just direct those to Jeff or Jill, and we'll make sure to answer those after the meeting today. So I want to speak to the data integration, we'll call it, essentially how your hospital gets your data from your system on your side into our solution. And I have Emily from Helen Newberry that I'm going to pull in and help speak to this as well. But we've really come a long ways in how this is set up. We wanted to make it as easy for you, the hospital, in terms of the process to get your data from your hospital to our platform. We also wanted to ensure that there was really clear transparency, and you saw that in the demo with those data dictionaries. So those three items that you see there: seamless data pull, simple upload process, and actionable insights. Emily, if you can just speak to that, the process that you are part of in getting the data to us, and then kind of that transparency that I've mentioned.
Sure. Definitely. One of our goals was to ensure that it was very easy to pull the data, because I know that many of us do not have large staffs. Uh, Particularly as this needs to be a repeatable occurrence. So the initial data pull, I think identifying those reports that we had to use, we use Epic and Multiview here at H&JH. I was able to get 3 of the reports out of Multiview, really just using that straight transaction data from the system. And then the 4th report coming from Epic. But again, it was a fairly standard report within Epic and not too difficult to build. I think probably in total, I spent maybe a day just doing the initial finding those reports. Sam was really easy to work with through this process. And I didn't need to do a lot of manipulation after the fact, pulling the reports out of the system. They were able to take what my system had and make it usable for the benchmarking product, which I really appreciate. I think moving forward, I was able to set up save queries for everything, save reports. So I do anticipate transitioning that process to the accounting staff. And I think that will take less than an hour a month or an hour every pay period, whichever cycle we decide to upload. And that really it's not going to need involvement from me as far as the pulling the data moving forward. Also to the other piece, I know that Sam mentioned just the transparency. One key factor in this process is ensuring that, we're comparing apples to apples. For instance, visits are comparable between the two at one point in time during this process. So you'll go through and you'll identify which charge codes equal a visit. And at one point, I noticed there was a little bit of a discrepancy between our hospital and then Kalkaska in terms of productivity. In one department where I felt like, I really think our productivity is pretty good. So what I was able to do because of that data dictionary that Sam was showing was I looked at what Kalkaska was calling a visit versus what our hospital was calling a visit, and I noticed that there was a difference there. And just looked to Sam to provide more clarification on what exactly do we want to define as a visit. And I think we were able to through that process achieve more comparable data. So
Yeah, thank you, Emily. That what you just described there is exactly how that process should unfold. We want to make sure that we're comparing things appropriately and evenly across all the participating hospitals in this. So the process that you described, Emily, of what you noticed, the action you took, and then how we got that reconciled was great. So thank you for sharing that, Emily.
Good afternoon, everybody. My name is Paul. I'm with Eide Bailey. And one of the things that we talked about early on when Jeff was talking about when we got together about a year ago was to make sure that our productivity analysis from peer to peer was really solid. And as Emily said, that we're, pulling the data and organizing the data in a way that we can get a true apples to apples comparison. I'd like to introduce Terry Lutz to the conversation. Terry was very helpful as we were putting together the productivity work to make sure that we were keeping apples to apples and making sure that we're answering that question for that comparability and that transparency across the state of Michigan. Terry, if you could pick up the conversation here a little bit and talk about your experience and what we're shooting for, that'd be great.
Okay, thanks, Paul, and welcome everybody. I just getting involved with this. I mean, it was one of those opportunities to, and since I'd been involved with back with Jeff when we had initially done it through it the Rybar group, and had put together some, had started on particular departments and tried to do something that wasn't going to take us forever to put together, and you tried to match up things, but. Initially, what I brought into it was basically looking at it from that view, and looking to make sure that our what it would take to put it together, like Emily talked about, was going to be easily done once it's set. I mean, it takes a little work to get it started, but once it's set up and rolling, then it's more easily pulled, and it is not as much of a burden as what we actually ran into, and it kind of made it all fall apart on the other when we were doing that before. But then also making sure our time frames were matching up, and that was one of the things that we were as we were looking at, we weren't quite matching up, and so we pushed back in terms of just saying, how can we make this work? So then the inputs with the payroll data match up with the outputs with the stats. And so by getting out into the very granular information and basically taking basically in effect dumping information into it for Sam was able to take that and put it into a mode into the so then we into the system, so then it would be matched up. So that's where I feel that from when we started with this process to now has been probably the biggest pickup, is so then we can do that. And then the last thing is just the idea that from day one when we did this a long time ago now, the idea was that you can everybody else's data. So then if one is doing significantly better, you can look at the data, but then also reach out to the CFO and reach out to those managers to make sure to find out, to compare operations, say, how is it that you are able to be that much more efficient than we are? And so I think that's one of the biggest pickups. And you don't always get that with survey data. Survey data was usually just it's very generic, and you can't actually drill down into it. And I think that's going to be a big pickup with this system as we get more hospitals involved with it.
All right, Jeff, you could forward the slide here. These are some examples of what Terry was talking about. And I don't know if you want to expand on it, Terry, but we're looking at the comparison of the three hospitals involved in the emergency room.
I mean the and what as you see here, it shows that in terms of productivity, it definitely looks like we're somewhere in the middle, at least the three. And the thing you do run into, especially the ED, you have certain base staffing pattern, and obviously, comparing three hospitals with a pretty significantly different amount of volume, that definitely causes some trouble when you have some certain base traffic staffing patterns. And so as we get more hospitals, you would expect to see some groupings, hopefully, of different hospitals with similar volumes to help flesh out whether or not there's one that sticks out. Because obviously right now, Helen Joy Newberry runs into that, where, at 5.61 versus hours per visit being quite a bit higher than Kalkaska at 4.3. But it's trying to work through this, and as you have more, it becomes more valuable as you have more hospitals involved. That's what I feel is where we're at right now. Now that it's set up, now that I feel we have our comparables in good spots, now it's starting to, seeing who else is interested in being involved and trying to figure out how to get it populated, get everybody started up, and then start comparing.
Awesome. Thank you, Terry. Jeff, we've got Andrew coming up next. And Andrew, I know you've got a hard stop at 1 or in about 12 minutes here, so I don't want to take up too much time. Andrew, I'd really like the way you talk about the comparative analysis with the hospital. And we've got some kind of neat views here we'd like to share. And welcome, Andrew. And thank you for being here.
Yeah, thanks. I'll just kind of pick up a little bit where Terry left off. I think, those of us that were around for some of those early iterations of the benchmarking tool, this version has significantly more components to it. I think some enhancements as well. Not only is it easier to get the data, Sam's doing a lot of the back end work on that data, but if you want to roll to that next slide, this was what I think is a pretty significant enhancement in this tool versus some of those previous versions. So not only can you pick your cohort kind of by that gross revenue up there, but on this graph, you can kind of pick not all departments are going to be the same for all hospitals. So like KMHC, we only have 8 inpatient beds, so we're probably not going to benchmark well with somebody that's got the full 25 inpatient beds. Even though our gross revenues might be similar because of outpatient differences and things like that. But if you go and you look at a department, so this department's looking at just the lab, we might benchmark with another facility that might be of a lower revenue, but has that high volume, high labor lab quadrant mix. And so obviously with only 3 facilities in the tool right now, it looks a little bit mundane. But if you go to the next slide, what it could look like if we had 15 or 20 facilities involved, you'd be able to go and kind of pick your own cohorts based on where your metrics fall out. And I think that's rather than just looking at a at a gross revenue perspective, we're really going to this view and kind of looking at by department who are my true cohorts. So I mean, it's not always the same depending on volume on the department. So I think that's a really nice enhancement feature that this tool has that previous versions haven't had.
Nice. Andrew, thank you. We come up with that phrase best practice. We like to talk about it. I think what we're learning here is that with the data as a foundation to understand where we are, how we compare to others, where someone else is, that best practice conversation can really have some really strong credence. If you think about the productivity views that Terry showed with you and how the data was put together with Emily, everything is there to drill in and do some root cause and really find out where some of this variation is between facilities. So I think this is a pretty neat solution. Andrew, I know you got a role, but anything you want to add? Or
I mean, I think another kind of enhancement I feel like that we're moving towards here too is just the individual facility applications that this will have. I mean, we're all relatively small facilities. We don't have the manpower to create graphs and images and things for not only our management leaders, but maybe even for a board presentation or things like that. So you're able to have, there's a lot more visual tools that are available through this application that it would take quite a bit of time for someone to create. Here, they're obviously already available. And so, I mean, I think that that's another really important factor in this iteration of the model is just kind of being able to have those conversations. Not everybody is, you can't just throw numbers at a bunch of people. Some people are visual learners. And so having kind of some of those visual applications and visual models that are available really going into helping the managers of departments kind of manage their departments and understand where we should be, what the benchmark is, and kind of striving towards that benchmark.
thank you, Andrew. What's the next slide here? As we look at moving forward, there's this chart can be used in a lot of different ways. And as we move from facility to facility, the location of the bubbles or the dots is going to change. So what we're looking at here is getting into the rural health clinic, and Kalkaska is leading the charge here. So way to go. And Jill, you work a lot with the clinic, so please. Hello.
Yeah, good afternoon, everybody. I know not everybody knows me on this call, but I'm Jill Osterly, and I'm the Director of Provider Solutions and primarily work with the certified rural health clinics across the state. I know the majority of you, if not all of you, have some type of RHC attached to the hospital in a provider-based fashion. So I'm incredibly excited to be able to some of the impact that RHC data has on your organization. We are a leader across the nation in supporting the RHCs, and to bring this aspect in really allows us to have a bigger and broader impact at really looking at the benefits of bringing some of that RHC data to the CFOs and understanding the productivity level, knowing that there's some regulations around productivity level, around no-show rates, around some of the other attributes that the iBailey team have been able to build into this. So incredibly excited to be able to see this and leverage that to the greater good. So Sam, I don't know if you want to explain those two slides or kind of give some insight as to, because RHC data is a little new.
Yeah.
If you want to provide a little bit of insight to these, we've talked a lot about during this pilot project about the RHC data. And Sam, if you want to give a little insight, I think that'd be great.
Yeah, you bet. Thanks, Jill. And I match your excitement for having RHC data part of this solution and allowing organizations to understand what their peers are doing in terms of volume and staffing and productivity. So with these next couple slides, these two dashboards, we just wanted to provide kind of a glimpse into what that looks like. You saw some of this in the demo, but here we're looking at the RHC and we're looking at staffing so far across the three organizations that you've heard from today. But the neat thing that I really want to stress is, and Terry alluded to this, but the granularity at which we're getting the data and presenting the data. So we're not just providing kind of a rolled up a flat number of hours across a year. We're providing it month over month, which allows you to do some interesting trends and unlock some of those insights. But then also, as you see below, that skill mix. So we're taking the payroll data and those hours for employees, and we're categorizing them different ways. So you can start to understand how your organization might staff, in this case, the RHC, maybe a little bit differently than some of your peers. And if their productivity is perhaps where you want to be, that's where you can start to leverage some of that peer comparison and understand what somebody else is doing and how you might benefit from that. And then this slide is showing the flip side of the equation, so showing the volume. So again, we've selected the RHC department over on the left-hand pane you see there. And again, here there's a trend component, but when you're looking at productivity for the RHC or any department, you obviously need to understand the volume that's happening. So this is where you can kind of zoom out from that productivity number and look at, period over period, whether it's month or even every 2 weeks, if you want to get more granular. You can look at, how your RHC is performing in terms of volume. That lines up with your peers, or see if you're a little bit below or beneath where you might expect to be. And again, with the monthly data and even here the bi-weekly data, that's where you can start to understand maybe some seasonality things or things, again, insights that are at a more granular level than you'd probably be able to understand otherwise. So we just wanted to kind of show these two dashboards and offer a glimpse into what that would look like for the RHC now that it's part of the solution.
Awesome. Thanks, Sam. All right. I wanted to share this quote from Terry Lutz, CFO, Sure Health. It reads, "We wanted to move forward from our original solution and ensure we didn't repeat what we had already experienced. The new solution is built on transparency, collaboration, and actionable insights, making a real difference in operations." And, I think this highlights, a concern that many hospitals face, learning from past experiences to avoid inefficiencies. Terry's feedback, as well as other CFOs, really influenced the development of this new COB benchmarking solution. Honestly, their input helped shape it to be more transparent, more user-friendly, and provides actionable insights, avoiding the challenges that we've encountered since we've been doing benchmarking. I think it takes the new solution is not just a technical improvement, it's really a practical tool that meets the needs of the Michigan hospitals now. And obviously, go ahead. Sorry, Jill.
I was going to say, if I can just add a couple 2 cents, when this collaboration started back last year directly at the Critical Access Hospital Conference, we really pulled in the insights from the CA CFOs and really want to, from the state office perspective, help get you all engaged with a tool that's beneficial for you. It's one of the things we get funded under our flex dollars. It's one of our charges from the Federal Office of Rural Health Policy that we have to include this, but more so giving you all a tool that's really robust and something that's beneficial to you all. So we're really, really proud of the work that this team has done and really looking forward to some of the positive results.
Darn it, got me with the mute button. Sorry about that, everybody.
No problem,
My
Houston.
my name's Houston. I'm with Ide Bailey and have been part of the team kind of working on this over the last year. And I think my contributions have probably been the least important in terms of getting to what the solution looks like, but it's been great to be part of the process. And I just want to reiterate what a joint effort this has been, not only between MCRH and Ide Bailey, but between a number of the CFOs and representatives, a lot of people on this call. And I think what was really cool to see for me and being part of this was really the spirit and the intent that went into this. Not only was there a desire to create a tool that provided good data, but as has been mentioned a couple of times, to be able to do something that actually gives you as hospital leaders the ability to empower your teams and to be able to make decisions based upon that data. So not just knowing where you stand, but giving you the ability to reach out to your peers, understanding, sharing information, and being able to get better for the communities in Michigan, right? I mean, ultimately, we're in healthcare because, we want to take care of people. We want people to be healthy. And the parts we play from a business perspective and monitoring these metrics and running businesses is a huge part of that. So the collaboration has really been remarkable, and it's been fun to be part of that. I want to especially thank Jill and Jeff and others at MCRH because not only have they dedicated, I would be willing to bet, tens of thousands of dollars worth of hours over the last year, but they've also been able to provide some funding to help make this project and this product available at a price point that I think is really impressive and manageable. We all understand the economics of critical access hospitals and rural health in general. And having all the great tools in the world or having access to them is nice. But if you can't afford them and you can't make it work, then it's kind of meaningless. So that was a big part of our emphasis as well, is not only to create a great tool that was going to do what was needed to do, but to be able to make it affordable for everybody. So that's part of what I want to talk about today is MCRH has been able to grab or allocate some of the flex dollars to help this. In conjunction with that, Ide Bailey has been able to, as a recognition of the efforts put in by MCRH, we've significantly lowered the standard pricing of the solution to try and make it affordable for everybody to get access to. Specifically, what that means is a product like this that we're selling across the country typically has an implementation cost of $18,000 to $20,000. We've basically, for this group, have fixed that price at $12,000, so at minimum about a 35% discount, maybe a little bit more. And the subscription is normally around $1,250 a month. And I think we've made this very attainable by putting the subscription at $500 a month for each of the hospitals to have access to this. Additionally, and I think this is amazing, and I want to really emphasize this, for the hospitals, part of this group in Michigan, that will sign an engagement prior to December 15th of this year, Jeff and Jill and team have made available $39,000 that will be divided equally upon the organizations that join up. So the actual amount that each hospital will receive is going to be dependent upon how many sign up. But what I love about this is an incentive to help you help build that pool of data for everybody. The dollars that are shared out of that $39,000 pool will be applied against that implementation fee. And so, realistically, I would expect that everybody's going to have a number much lower than that 12,000 that we're looking at. So I think the financial contributions are very worthwhile. I think the time and efforts have then been put in far surpass what those dollars are. And I really encourage you on this call today to talk to your peers, Terry and Andrew and Emily, about their experience so far, and to reach out to Jill and Jeff and ourselves at Bailey if you have questions, because this is a phenomenal offer that really only gets more valuable the more hospitals that sign up. And we'd love to help facilitate that so everybody can get a piece of that $39,000 and we can get the system up and running as quickly as possible for everybody. Thank you for that.
Thank you, Houston. All right, so we're nearing the end. I think a couple of the big things by joining the initiative, I think the organizations that join are going to have some great benefits. It's designed to help hospitals optimize operations, unlock new efficiencies, and achieve best practices. And the thing is it's backed up by data. We actually have data to prove that. And, but think of it this way, you're not just improving your organization, it's contributing statewide. It's going to have a statewide impact, helping improve healthcare across Michigan. So, and as Terry and Andrew and Emily have mentioned, collaboration's going to be a key here. It's working closely with your peers. I understand some people work together because they're close in proximity, but you're gonna know somebody that's more like you in some categories that you can reach out to and work in collaboration. So I think it's just a great opportunity. And that is the conclusion. As Jill mentioned, or Houston, or anyone else, if you have any questions or need more information, just don't hesitate to reach out. Reach out to the three hospitals, Emily, Terry, and Andrew. If you have any questions at all, we will definitely get back to you as soon as possible. I thank you for your time today, and I hope it was very worthwhile, as we believe it was.
Thank you, Jeff.
And Jeff, if folks want to engage in this and get signed up, should they go ahead and just email you and we can
I
get the
think
ball rolling for them?
that would be the best. That'd be the best thing to do. Correct.
Awesome. Thanks, Jeff.
Awesome. Thank
Appreciate
you.
it.
Thank you, everyone.
Thanks, everybody.
And if there's questions now, we can take them now as well.
What systems are the folks using to grab their data from right now? Anybody use CPSI or Cerner in the clinic?
Our data mainly came from Epic, and then Paycor for our payroll. So anybody that's on Epic, it's really, it really worked very slick. And, Paycor actually, I think generally, as long as you have any payroll system is going to be fine. It's as long as it gets down to the detail, it shouldn't be an issue at all.
Do you have any comment on that?
Yeah, I was just going to say, Gail, I don't think any of the three that you heard from today are using Cerner, but we've worked with Cerner in other organizations outside of Michigan. So we've worked with that system and feel confident in being able to obtain the necessary data. And we have a document that was kind of mentioned in terms of the requirements of what the different reports need to have. So that'd be something that I'd be happy to connect with you on, and just so you feel confident. So you can look at the different reports we're asking for and what ultimately needs to be part of those, and whether that's feasible, which I would feel pretty confident that it is. But I'd be happy to look at that with you, Gail.
Yeah, I'd be interested in seeing that if I could, please.
Yeah, absolutely.
Jeff, do you have Gail's information so Sam can connect?
Oh, most certainly I do.
Okay, awesome.
Sam, this is Amy Rudicelli at McKinsey. Gail actually had the same question. We have CPSI, so I have a concern there. So I would be interested in that document as well.
Okay. And if you guys want, I can sure provide the document. If you'd want to hop on a call, as long as you're both on CPSI, the three of us could hop on a call and look at it together, just so that nothing gets missed in translation by just sharing the document. So I think I actually have both of your contact information from prior years. So if that works for both of you, I'll follow up with you, okay?
Hi, Sam. This is Christy at Harbor Beach. Can you include me in that as well? Because we also are on CPSI.
Yeah.
And Newton at Sheridan Community Hospital.
Okay.
I'm game for a call.
Yeah,
Yes, I am as well.
numbers grow, I think that's our best option.
Yeah, definitely.
Yeah. Can I suggest we just coordinate another little group call? We'll have everybody on it.
Yeah.
And Sam, maybe you can prepare some materials ahead of time so we can be more
Yeah.
efficient on that for
Yeah.
everybody.
I'll send out a doodle poll and we'll get a time and date that everybody can meet.
Yeah. Great question. I don't know how many people are still left on, but are there other systems that you just kind of want to toss out so we can be aware of those quickly that you're using that you might have some questions on?
So we use ECW and CPSI, and then for payroll we use Paycom. So.
And we're using Meditech.
Sure.
And we worked with Meditech. Is that Michelle who spoke?
Yes.
Okay.
Is there any more questions or from the group?
Hey, Jeff, I want to make one more comment that
Sure.
I didn't think of earlier. Without getting into a ton of detail, I work with organizations all over the country on these types of things. This is really cool what you guys are doing in Michigan or what we're doing together. And I think there's an opportunity here, not that it necessarily shows up on a financial statement anywhere, but I think this shows up in a way of being able to lead the country in how a state can work together to share this data with each other and kind of collaborate. So it's kind of, I guess there's some intrinsic value to it to also be a leader. And I think this is something that as it proves its success will probably spread throughout other states and around the country. And again, just my kudos and congratulations to MCRH and the folks on this call for being part of that. I just think that's kind of cool and appreciate being able to assist with that in some way.
Thanks, Houston. We appreciate that. We really do love being at the top of the pack when we compare ourselves to other state offices. And we strive, you all know our leader in chief, John Barnes, and he strives to do our absolute best for our hospitals and the clinics that are attached to them and everybody else that we work with. And I think this is just another tool in our toolbox to be able to do that. So appreciate the comments, Houston.
Absolutely.
Thank you.
Okay.
All right. Doesn't appear that we have any more questions. Like I said, I will get that doodle poll out and we'll get a meeting scheduled for all those folks that had CPSI.
Perfect. And just one last reminder, if anybody's interested in finding out more, reach out to Jeff. If you'd like to take a look at what the engagement looks like or the agreements, those are pretty much put together. We can get those out really quickly as well. And would love to start adding some people to the roster here.
That would be fantastic.
Thank you, everybody. Have a wonderful afternoon.
Thank you, everyone.
Bye-bye.
Thank you.